Well, thank you for being here. I hope the conference is going well. I'm Dr. Mike Ulisse, and I'm going to talk today about the role of the radiologist in breast care with the idea of can we become more clinically oriented and should we become more clinically oriented? Over the, 25-year career, I've had my sticky fingers in a mix of academics and private practice. I'm the former director of breast imaging at the UT Southwestern Medical Center in Dallas, ran the teaching program at Parkland Hospital. Retired in 2017, and they asked me to stay on the kind of the retired teaching and research faculty. I still help out there periodically with lectures and some research projects at the Health Sciences Center based in San Antonio. And I also am a co-owner now of a couple of breast centers in the bedroom communities of Seattle, Auburn, and Federal Way. We may have an association with Reyes Radiology. Sadly, like Debbie said, I have nothing to disclose. But if anybody out there wants to help me disclose things down the road, I'm happy to listen. All right, why is it important? What is the traditional role of the radiologist? And how is this role changing? And should the role change? I'll try to do it with not only some didactic teaching, but some case examples, and save time at the end for questions. Okay, I know that in Sunday and Monday, especially Tula, Dr. Distonis reviewed many of the things about breast cancer, the statistics, so I'm not going to spend too much time here. But we know that in the United States alone, it's about one case every 3 minutes. A fair amount of women get breast cancer, and it doesn't include DCIS with some of the statistics, and about 43,000 deaths in 2022. We know it's probably one of the most feared cancers. It's one of the most scrutinized cancers, largely from the medical legal community. When I was running the center at UT Southwestern, I commuted over a freeway. I stayed on city streets, but I would drive over this freeway called Central Expressway, one of the main arteries in Dallas. And on Central Expressway, they had this attorney's office. I would say a couple 100,000 cars morning and evening pass by this guy's office. Now, that's his shark on the roof. He does traffic accidents. He doesn't do med mal. The med mal guy is around the corner. He doesn't have a shark on his roof, but he probably has one in his heart. Well, we know that breast cancer has a natural history. If that woman does not get a mammogram, or if she gets a mammogram and we fail to detect the breast cancer on that mammogram, it will over time grow, and sooner or later it will become palpable. Well, women don't come in when they first feel the lump. They've got a lot going on with their plate, maybe with their families, their kids, with work, a lot of different things. Or they might think, well, it's a cyst, it'll go away on its own. And we don't see it maybe till it's later invasive, maybe even node positive at that time. The thing is, we don't do women any good by picking up a breast cancer that's already palpable. Yes, we can be sympathetic, we can be empathetic, we can help her through a critical juncture in her life. But where we make the most difference for the woman is if we can pick up that breast cancer before it becomes something that she can feel. When it's early invasive, maybe 1 centimeter, 1.2 or 1.4 centimeters, or when the calcs first become visible on the mammogram, and we're picking up 3, 4, 5 millimeter groupings of calcifications and doing a stereo biopsy, we can make it a speed bump in the woman's life, not a major disaster. And that's one of our goals in breast imaging. So, we don't know what the cause of breast cancer is. A lot of things have been we're still working on things. One thing we do know that probably 75 or 80% of women who get breast cancer have no real identifiable risk factors. The majority are not genetically linked. The minority are. So we also know that we have excellent long-term survival statistics if we can catch it early. So, what are the things, when we're delivering breast care as breast radiologists, we obviously have to be efficient in clinic because not only are reimbursements low, but the workload can sometimes be pretty heavy. We have to be timely for the woman, though. Waiting, 3 or 4 weeks for a recall and another month to get a biopsy is probably not very efficient. Not only is it psychological torture, it's just not really, not the way I would want to be treated when I'm on that side of the table. And we want to limit patients from getting lost or lost to follow-up. I used to do a fair amount of root cause analysis investigations for our hospital, for sister hospitals, for the state of Texas, the medical board. Now I'm doing them in Arizona and a few other places. And I can't tell you how many times the woman said, I had a biopsy, but nobody called me. You come back a year later and the cancer is twice as big. I didn't get the results. Nobody told me. I figured if it was serious, somebody would call me. And you want to limit things from slipping through the cracks. And that has certainly happened several times in my experience. So let's take a look at the role of the radiologist in the delivery of breast care, old versus new. What I'm talking about is the traditional model versus what I want to propose as a new model. Thinking about what we do, we read screening mammograms, we read diagnostic mammograms, we read and perform breast ultrasound, read other studies such as breast MRI, and we perform various biopsies. And we'll look at this in a traditional model of radiology and breast care under the traditional model of radiology versus someone who might become more clinically oriented. If we look at the traditional model of breast radiology, we have a presenting problem and a sequence of care for a woman, and we have a role of the radiologist. In the traditional model, the role of the radiologist is more secondary. We kind of take a back seat. We're a doctor to another doctor, and we give a weather report or some other kind of radiological information to a family practice doctor, an internist, a surgeon, an orthopedist. But we don't take an active role in patient management. So in a breast problem, let's take a look and see how this plays under the traditional model. This is a case review I did. It wasn't too far from here, actually. It was in Florida just a few years ago. It was about 7 years ago, 7 or 8 years ago. Remember the 15th of January, okay? The Ides of January. Woman goes to her family doctor a week before and says, I feel a lump on the left side. And the family doctor, I guess, doesn't examine all, sends her for a mammogram. She shows up at the mammogram center. She has a BB here, and actually she had a marker triangle here, and there was a triangle down here more anteriorly, so 2 lumps. But they do it as a screening mammogram because their schedule is full. They don't have time for diagnostics. And plus, she hasn't had her mammogram, so she can't have a recall yet. So for whatever reason, they do it for they didn't mention, technically limited study on this side, can't see the axillary tissue. And after she has her mammogram, the woman asks the technologist, did you see anything? What's there? And the technologist says, I can't really say anything. Your doctor will get a report in a few days, and you should get a call from your doctor, certainly within a week. So on the 19th of January, indeed, she gets a call from her doctor, and they say, we need to get some extra views. Okay, we think that the radiologist thinks that there may be a lump on the left side, and he wants some extra views. So on the 19th of January now, 4 days later, she gets some extra views over here. And the report says, indeed, there looks like there's a lump on the left side. She needs an ultrasound. But at the time she left on the 19th of January, she asked the technologist, do you see anything? What's going on? The technologist says, I can't really say anything. Your doctor will get a report in a couple of days. And indeed, she gets a call a few days later from the doctor, and they say, well, they saw something on the extra views. They want to do an ultrasound. So now on the 21st of January, she goes back to get an ultrasound, and indeed, they see something on the ultrasound, and she asks the technologist, what do you see on the ultrasound? The technologist says, I can't really say anything. The doctor will read it. Your doctor will get a report in a couple of days. So now on the 25th of January, indeed, she gets a call from her family doctor and says, they want to do a biopsy. So instead of booking the biopsy, she ends up to see a surgeon. I don't know why she saw a surgeon before the biopsy, but she did. And I'm not diminishing the role of a surgeon, but what's a surgeon going to say? You don't need a biopsy? So she sees a surgeon on the 8th of February. Then on the 18th of February, she has a biopsy. Still, nobody's really talking to her, and not even the guy doing the biopsy. And on the 22nd of February, she gets a call with the results, which you know is breast cancer. So from the 15th of January till the 22nd of February, nobody has really given her any useful information or any kind of information other than, they want to keep doing these extra studies, and that's how long it took for her to get the results. Well, I think we can do better than that as breast imagers. But why is it? What is it that makes a breast consultation different than other radiological examinations? If I see a woman come in for belly pain, so we're doing an abdominal ultrasound and we see gallstones, how come I don't jump in there, consent her to do a lap chole, get some anesthesia, stick some tubes in her, and take out her gallbladder? I don't feel I can do that in that area of radiology, but I do feel I can do it with breast care. Why? I was thinking about that. Well, I think that when we talk about breast care, we really only have one real question to answer. And that is, does this woman have breast cancer, yes or no? There are a few other things, but basically we just want to know, is it cancer or is it not cancer? With the abdominal pain and the gallstones, those gallstones could have been there for a decade and they could be asymptomatic. And really, there's other clinical information. Maybe she's an alcoholic and has pancreatitis, or maybe there's something else going on with, atypical appendix pain or who knows what. What's her white count? It's probably better with abdominal pain. The differential diagnosis is extensive. It's as long as my arm probably. And it's better for one doctor to coordinate the radiological tests with the clinical laboratory tests, with the physical exam, with the history and past medical history and medications that she may be on to arrive at a more appropriate diagnosis or a more limited differential diagnosis. But in the breast care situation, if a woman feels a lump, what we want to know, is it cancer, is it not cancer? We can live with fibroadenomas, fibrocystic, sclerosing adenosis, and a lot of other stuff. So I think that is what, for me, allowed me to think back in the mid-1990s that I can act more like a primary care doctor for that woman's breast problem until we make a diagnosis. And I think it's because we can be more efficient in clinic by me just controlling everything. We can, give very timely care to the woman. Very often she'll come in. Now she gets a screening mammogram, but we'll get her back in 1 or 2 days. And if we see something we can't do a stereo right away because that's pretty much got to be prepped in the room and stuff. But if we need to do an ultrasound, we'll do it right away. An ultrasound guided biopsy, we can get her in that day, maybe the next day, depending. How late in the afternoon it is, but we can certainly give timely care to the woman, and we can limit patients from getting lost. Because if I do the biopsy, I call her with the results, and then I say, it did turn out to be cancer, but this is small, this is tiny. We can make this a speed bump in your life, not a major disaster. Call Dr. Smith, get hold of him or her, and he'll get you set up for surgical referral and things like that. And we can make sure that things don't get lost to follow up. So I think the model is changing. I believe we're evolving into more of a clinical breast radiologist, clinically oriented. When I issue a report, I don't sit there and say at the bottom of my report, clinical correlation suggested. I do the clinical correlation, and we'll explain that here in a minute. I don't say don't let clinically suspicious mass delay biopsy. There's no hedges on the bottom of my reports. I just say what I see, what I think, why I think it, and what I recommend with a family member. And then I talk to the patient and do it. And really let's take a look at the opportunities that are available in the diagnostic clinic. First of all, you can talk to patients. Now, this is from probably the year 2000 when I was first doing this talk in the med school. I helped my partner and I in the Dallas-Fort Worth area. We built 5 different breast centers, and then we ended up selling them, and that's when I was recruited to become director of breast imaging at Southwestern. But I finished my fellowship at Southwestern, and I stayed on the teaching kind of clinical faculty to go back once a month and give board reviews and lectures to residents and things like that. I guess they thought I did okay. But way back then, maybe it came from my family practice roots, because when I first started and graduated from med school, I had a Navy scholarship. I did family practice, did my payback time, and then I went into radiology and then breast imaging. But I figured, why not talk to the patient and go over her films with her? And even though that was from probably 99 or 2000 when I took that picture, this is just about a year or two ago, I still do it at my clinic in Seattle. I go over things with the patients, not every case, but if there's anything that the patient's wondering about or there was something that was a little different, I said, this is what we saw, and everything turned out okay. Why do we have to put clinical correlations suggested on the bottom of a report? The breast is already lubed up with jelly, so what better time to do a physical exam? You can do a physical exam, you can trap the lump in between your fingers, you can put the ultrasound transducer on it, and you can tell the woman, yeah, this is a benign simple cyst. It's okay. If it bothers you, I can give you some numbing medicine, I can drop a needle in here, I can make it go away. Can't guarantee it won't come back. Or, some women have breast tissue that's more sensitive than other women, so they're prone to form cysts, and you're probably one of those women. So even if this goes away, you might get another one. It could go away on its own, but this is a little big. I'm not sure if it will, but if it doesn't bother you, it doesn't bother me. Or if, you see something like this, a young woman, maybe she had just had a baby and now she feels this. Yeah, I'm virtually certain this is harmless. We have two choices. I can give you some numbing medicine, drop a needle in here, take some pieces out. We'll send them to the lab. They can look under the microscope. Or you know what? If you don't want a needle, we don't really have to do anything. I can just have you come back in 6 months and we can look at this and I'll show you nothing's changing. And if you think it's changing in 2 or 3 or 4 months, hey, that doc's crazy, something's going on over here, just come on back right away and we'll do the biopsy. Either way is fine with me. I'm going to sleep fine for 6 months. If you're not going to sleep fine for 6 months, we'll do the biopsy. If you are, come back in 6 months. A quick conversation. It doesn't take long. I generally try to sit down when I'm talking to a patient. I try to have my head, I guess I learned this from a lecture in family practice, my head level, eye level below theirs, and because they were usually sitting on the edge of a table after the ultrasound, and I pull up a chair and sit down next to her. I don't stand over her and tell her what's going on that way. I just have her sit up, and then I'll sit down. My head level will be a little less than hers. But, sometimes you feel woman comes in and says, I feel, maybe a new lump over here. And you do the exam, the mammogram is stone cold normal. You do a physical exam, and she's got that grainy, lumpy, bumpy texture. And you do the ultrasound, and the ultrasound is stone cold normal. And then why can't you tell her, look, I feel what you're feeling, but you know what? Your breast tissue changes composition all your life. It's not the same at 25, 45, 65, or 85. And maybe you're changing composition in the area. But I got 2 good machines that are great at looking for breast cancer, and I don't see any breast cancer. The mammogram looks good. The ultrasound looks good. I don't really feel anything that I would call suspicious. So you're good to go for 1 year. But you know what? This is my card. This is who you saw today. And if you think in 3 months or 6 months or 8 months, that doc's crazy, something's going on over here, you just come back right away. Or you know what? It's got my cell phone and my email on it. You can shoot me an email. You can just say, hey, doc, I think you're crazy. But otherwise, you're good to go for a year, and I'm virtually certain I'm going to be right. That way, if you do this 1,000, 2,000, 5,000 times in your career, you are going to be wrong once or twice. But she'll have your card. She'll think of you as one of her doctors, so that when you do make a mistake and she comes back, she'll come back to you and not your competitor down the street who really doesn't like you, and you might not like him either. So I think that's, and I've never had a patient abuse my cell phone number. And I give it to each one of them after a biopsy and say, if you need anything after the biopsy, you can get hold of me. I've never had someone abuse that cell phone number. I think we have the tools and the skills to do this. Who's in the best position to do it? How is a family practice doctor going to read your report about a potential lump and feel the lump reading your report and decide if it's suspicious or not? No. He or she's going to send that patient to a surgeon or something like that. But you can do it. You have the skills. You can do a physical exam. you have eyes at the end of your fingertips. That's the good thing about ultrasound. Not only can you correlate with the mammogram and the physical exam, but then you can put the transducer and have eyes at the end of your fingertips to see what that tissue looks like underneath. And you can do that clinical correlation for the patient, and you don't have to have a disclaimer on the report. I think ultimately, though, we have to ask ourselves, whose responsibility is it? Who has the tools, the skills, the training, the technology to do all of this, bring it together, and decide whether that lump is breast cancer or not breast cancer? Other things that we have to do, not only we talked about medical audits earlier, so I didn't really want to talk about it here, but we also have to make sure that our image technical repeats are one of the big pet peeves of mine because of mishap investigations that I have seen. But you know already that the pec muscle has to be relaxed, so it's got to be convex. You want to see it down to the posterior nipple line. About a third of your CC projections you should see pec muscle on the edge, and then you know your techs are doing a good job. And I tell the techs, don't make me do a technical repeat because I'll do it 100 times and I will never see anything, okay? So, if you shortchange the axilla, notice it yourself and just get the repeat exam done right then while the patient's there. Don't make me call her back because she's just going to drive around the parking lot 3 times looking for a parking space. She's going to get a door ding. She's going to be frustrated because she had to take extra time off work or something like that and come back for something that's your fault, not her fault, and it frustrates everybody. You don't get a chance to say that lymph nodes in the axilla are normal if you don't get a chance to see them, okay? But if you shortchange the axilla, you can do a technical repeat 100 times and you will never see anything until this particular year. And I think this was the year 2000, and Nivea was a technologist, and I'm in the diagnostic clinic and looking at that. And I said, I don't know, man, that looks a little shortchanged. She's still here. Go back and repeat that study. Don't make me call her back when I'm reading screens tomorrow. So she repeated it, and lo and behold, boom, a little tiny thing is hidden over there. So, but that will never happen again. You can do 100 technical repeats. It'll never happen again until June of 2018 when I had a different technologist, and I said, this was the next day I'm reading that screen, and I called her over and I said, that right pec muscle is shortchanged, but maybe the woman had a frozen shoulder. I don't want to make it a torture chamber. So I tell the technologist, if you notice it and you put a note in the record, best I could do, patient has a frozen shoulder, patient just had whatever, so if there's a reason, but you noticed it, that's fine. I'll read it and I'll say, limited study, but I can still interpret the rest of it. She's like, no, I don't remember any of that. I said, well, you got to get her back and we got to do a technical repeat. And we did. And lo and behold, right over there. And that was just a few years ago. It'll never happen again, though, until you're checking out radiology residents at the med school. And you know that you can get blur on various films, right? So this is actually 2011. And I'm checking out one of the residents, and he's like, well, we're working up the cancer on the left side, big spiculated mass, right? And I'm looking at the right side, and I said, I don't see the parenchymal bands as well on the right than the left. It's like there's some blur, especially on the medial side. I don't know. Let's have him go back and repeat the right side. And, again, it just looked blurred out, especially in this area over here, compared to the other side. So we go back and we do a repeat, and lo and behold, what do we see? A group of calcifications right over here. If we look at the before and after, they're right here. You can see how they're blurred out right over here. This woman had an invasive cancer on the left side, and we biopsied these, and that turned out to be DCIS on the right. But we did it both at the same time so that now this isn't cooking for another year or 2 years or something. She gets treated for the left side. She goes through all the rigmarole of lumpectomy, radiation, sentinel node biopsy, and then a year later, now that this comes out, because we didn't repeat the technical repeat of the film, that comes out, she has to go through the whole cancer treatment again for the right side. Get it all done at one side, take care of her, and of course, I think we had done an MRI and whatnot. But, it might not have shown up, those calcifications, if we had done an MRI even for the because of the left cancer, the calcs might not have shown up on the MRI, and she still would have had to go through the rigmarole a year later. So make sure you get good studies and quality images, and if you need to do a technical repeat, do it. It's frustrating for everybody, and you'll never see anything until June of 2018, but when it happens, it happens. What may be the most powerful tool of all, though, I think, is to become clinically oriented, to talk to the patient, to show her her studies, at least in certain cases. And I agree, don't throw stones. Think about how you would dictate a report and how you would talk to a patient if there's a missed cancer and the cancer was your miss from like 1 or 2 years ago, versus how would you talk to a patient and dictate a report if there's a missed cancer, you're reviewing it with a patient, and the miss was one of your colleagues at your center, one of your partners, versus how would you dictate a report and how would you talk to a patient if there's a missed cancer, but the miss was a radiologist down the street who doesn't like you and you might not like him. I would say do it the same way. Don't throw stones. Focus on what's there. We see this, there's an interval change. What we need to do is, find out what's going on with this change. And again, don't try to impugn somebody else, but focus on how you can take care of the patient with what is going on right now. It might be a missed cancer. The cancer might have been bigger, but, focus on how you're going to take care of her now. Because this is a true case. In May of, and I can't remember, it was either 2002 or 2003, long time ago, old analog image, but it was an important case for what I'm going to tell you next. My former partner at the time, this in my breast centers in Dallas when I was building them, he called this a benign simple cyst. I don't have the ultrasound from that day. It got lost. It was old analog films. But I know my former partner. He was a good radiologist, and there's no doubt in my mind that there was no doubt in his mind in May of that year that was a benign simple cyst. So he tells the woman, we can drop a needle in here if it bothers you. It doesn't bother me. At least come back in a year. But if you ever want me to drain it, come on back and we'll just drain it. So I'm covering in between the holidays at December, between Christmas and New Year. And the woman comes back and says, you know what? This cyst is starting to bother me. I want you to go ahead and drain it. So the first thing we do, since it had been more than 6 months, is we repeat the mammogram. Well, you look at that and immediately the hair on the back of your neck stands up, your heart skips a beat, you get a garlic or metal taste in your mouth. First you say it, then you do it, and you do that. So we went in, did the physical exam, did the ultrasound, and then I'm talking to the patient because, of course, we talk to our patients. We say, what's going on? And I say, I don't think that there's something going on over here. We need to do a needle biopsy. And she's now standing up. She's dressed. She's looking at me in the eye. We're going over the film, standing at the view box. And she looks at me right in the eye and she says, what about when you told me last May that it was a cyst? And the only thing that came out of my mouth was, I think we made a mistake and I'm sorry. Of course, I took a breath and I said, however, if you will let me take care of you, I will continue to take care of you no matter what you decide. If you'll let me, I'll numb you up. I'll drop a needle in here. We'll do a biopsy. We'll confirm what we think is going on. And whatever happens, if you'll let me, I'll continue to take care of you. And then I said, if you have lost confidence in us, in my center, in me, I will help you find a doctor who I would send a family member to. And she took a deep breath and she thought for three of the longest seconds in the world. And she said, okay, let's go. And so we did a biopsy, took care of her, and then the story goes on. Fast forward another year or so, I'm taking over. We sold the practices, and I took over as director of breast imaging at UT. And I get a call from the front desk. Hey, Mrs. Smith is on the line. Of course, I remembered the name, and I picked it up. I said, hey, how are you doing? I remember you, of course. He said, you moved, you're gone, and you told me you would be my doctor. And I want to come see you at the med school. And I can't get an appointment. You got to help me get an appointment. I was like, oh, okay, yeah. Because you said you would be my doctor, and you said you would take care of me, and I'm holding you to it. I want to come see you. And, I almost started to cry. It was a true story. And I think that if we take care of patients that way, I think we will do more to hold down medical liability than we ever will to foster it. because patients know that we're not perfect. They can accept that we're not perfect. What they want to know is that we care about them. We're caring physicians who are concerned about their medical problems, and we will help them through whatever critical juncture come up in their lives. It's like the old Patch Adams thing. If you take care of a disease, sometimes you win, or if you treat a disease, sometimes you win, sometimes you don't. But if you treat a patient, you win every time. We may not be the primary doctor, but I don't think there's nothing secondary about what we do. I've been practicing this way for years, and I've been teaching it for 24 years, and, I've never looked back. So, I don't know if we have to do it again, but this is the repeat of the poll EV question after this lecture. Do you think that as a result of the lecture, you now feel that it's beneficial to interface with patients and become more clinically oriented? Yes, I do. No, I don't. Or some of the above, but not all. And so I guess I was preaching to the choir. But we're going to end on a left CC mammogram because sometimes, you see benign calcification. Sometimes it's just a left CC mammogram. But when I saw this, I saw a bunny rabbit. There's the head, the eyes, the mouth, the neck, the ear. And my point is that sometimes there is more art than science in breast imaging. And that's my story. I'm sticking to it.